Thank you. Welcome everyone to MVC's Cardiac Rehab Workgroup, our first of 2025. My name is Emily, and I'm one of the site engagement coordinators with MVC, and it is my pleasure to be facilitating this workgroup for you today. We're just going to start off with a couple of housekeeping items. First, this workgroup session is being recorded as per normal. The slides and the recording will be made available to you following the work group. Be on the lookout for our follow-up email with links to those items. Second, a reminder to just please double check that your mic is muted throughout the presentation unless you are unmuting to ask a question. This just helps us reduce the background noise for the recording. And then we will be monitoring the chat throughout the presentation, so feel free to pop any questions that might come up throughout the presentation into the chat. If it's something that we can answer along the way, the MVC folks that are joining us on the call today will do that. Otherwise, we'll hold those questions until the end of our presentation today, and we'll have a designated Q&A session. Regarding P4P, for those that are attending this work group for P4P credit, we look forward to your active participation throughout the work group. For our work groups in 2025, this can include responding to polls, questions, discussion, and participating in breakouts. We will primarily be engaging in a Q&A and discussion at the end of the presentation today. Additionally, we will be sharing that post-work group survey at the end of today's work group. We'll put that link into the chat at the end of the presentation. It will also be available in the follow-up email if you're looking for that. For hospitals participating in P4P who would like to receive credit, that survey is mandatory to be completed. And as a reminder, please note the hospital that you are attending on behalf of on that survey so that we can appropriately allocate your attendance credit. And also only complete one survey for this work group for your site. Just a brief agenda. First, we're going to hear from Dr. Stephen Keteyian on a non-traditional approach to cardiac rehab, hybrid cardiac rehab, and then we will follow that up with a discussion and Q&A session. All right, so today's presentation is going to be led by Dr. Steve Keteyian. He's the Director of Cardiac Rehabilitation and Preventive Cardiology at Henry Ford Health. Some of you may have attended the MyCR meeting earlier this fall and saw Dr. Keteyian present. We wanted to bring him back so he could continue to elaborate on that conversation. So I'm going to pass the slide sharing over to Dr. Keteyian. All right, you should be able to share your slides now.
Thank you, Emily. Let's see if I can get this correct. How'd we do?
Like it's still waiting for you to share. Let's see.
Interesting, because I did. Let me try again. Oh, no, I didn't. Hold on.
Sometimes it's a two-step.
Yep.
There we go. All right. And then, yep.
Full screen?
Yep, you've got full screen.
Let me try one other thing.
All set on our end.
Okay, good. Well, thank you for the invite to present. Maybe a quick apology before I start, because some of you may have seen this full presentation before. And if so, maybe it's nap time, but it will be kind of granular. I'm going to get into somewhat detail about hybrid cardiac rehab, show some of our data and some of the challenges. Hopefully for many it is helpful. So it's probably best just to level set everyone's understanding about cardiac rehab. For many of you, this will be known background, but for others may be helpful. So the qualifying event for early outpatient, sometimes called phase 2 cardiac rehabilitation, are those that I've listed here. And no surprises, most all of you probably are aware of this. Just to highlight, for patients with stable heart failure with reduced ejection fraction, they only qualify according to Medicare and many commercials is if the ejection fraction is less than 35%. Also, the map I've shown you, big circles in red are the 3 Henry Ford Medical Group cardiac rehabilitation sites in the Detroit area. There's 4 boxes with kind of like an exclamation marker in them. Those are also in Henry Ford Health, but outside the Henry Ford Medical Group. So my connection with those groups is collegial rather than, let's say, direct report. Not on this map is former Ascension sites that have cardiac rehab. We're still trying to work that out. Busy slide. On the left is the graph for the number of patient visits that the 3 Henry Ford Medical Group cardiac rehab sites perform each year. You can see the dip due to COVID in 2020, but since then a pretty steady incline, and we're well above 20,000 patient visits. So this is a moderately sized plus adventure within the health system for us. On the right is the nice infographic that came out from AACVPR and American Heart Association just within the past 2 or 3 months. But it represents what I've always tried to convey is that cardiac rehabilitation is not exercise only. It's a comprehensive core component program that looks at not only supervised exercise, but activity counseling, weight management counseling, working hard on hypertension, diabetes, smoking cessation in terms of and lipid management, but not only in terms of lifestyle, but with primary care or cardiology care to make sure patients are achieving goal. And then there's hopefully a strong behavioral care component for depression or anxiety. So this is data that you all may have seen for your own hospitals before. So I'm showing our laundry, so to speak, for Henry Ford. And just so we're clear, this is a performance metric for AHA and ACC. It's the rate of cardiac rehabilitation use, and it's the number of people we enroll in cardiac rehabilitation divided by those that are eligible within 90 days after hospital discharge. The national target is 70%. Henry Ford is shown in blue. State of Michigan data that we get from you all is in the fuchsia color. And then blue is data that we've published using CMS data. So it's a slightly older population, but true nonetheless. And you can see that for a couple of our qualifying index events, Cabbage and Saver, we're doing pretty well. A little bit ahead of state and certainly ahead in some cases of the national data. But for others, any PCI, TAVR, we're struggling at, let's say, 35 to 40% or so. And not unlike other programs in the state, for AMI only and for heart failure, we're way behind where we should be in terms of target. This is Henry Ford Hospital data, Detroit. And this is Henry Ford West Bloomfield Hospital, doing a little bit better for PCI, above 50%, a little better for acute MI at near 30%, but still both are below target. And again, dismal for heart failure. And this isn't, whereas the other index events have good referrals in the US being accomplished across the US, referrals for heart failure are not nearly there, which is driving, I think, the low utilization rates that you're seeing. So when I talk about hybrid cardiac rehabilitation, what specifically am I referring to using let's say, a virtual platform? On the left there, you can see, so it's a patient-centered approach, and as the name suggests, hybrid. It's a mix between both facility-based, which you see on the left, brick and mortar, and remote. Now, whether that's done, in the patient's home, whether that's done in the community, whether that's done at work, all of those would apply. We try to really reinforce at least one visit in the facility-based, maybe up to 10 or 12 or so. And then if the patient says, hey, you've got me for one visit, and then the rest I'm going to do virtually, we're okay with that, as long as clinically they're okay with it. We're okay with it. But it could be up to 35 then virtual sessions. Most often we get patients to do about 10 or 12 facility-based and the rest virtually. And we'd like some some facility-based, because we can do their individual treatment plans in person rather than having to do those virtually. We can just check in with them, whether it's blood pressure or questions or comments, clinically check them. So we like that mix if possible. Again, I've listed out the qualifying events, and I've actually listed out the core components there that we try to work on, in addition to go beyond just supervised exercise. So what are some of the strategies or issues that might drive the use of hybrid cardiac rehabilitation? What's the underpinnings that might push us to using it? From the patient perspective, they might have dependent care duties, return to work issues, live a long ways away. Picture yourself in up north, the UP, and the closest hospital is an hour and 15 minutes away. So it's travel distance or transportation issues and individual comfort. There's some populations that just don't want to exercise in front of other people. And we have to hold that for just a second. And we have to, adjust for that. At the system level, some health systems can't handle the volume they have, so there's a physical space, equipment, FTE resources that prevent us getting to our waiting list. So to have an alternate way to deliver it is helpful. And maybe the referrals to cardiac rehabilitation are excellent. We just can't get the patients in. Then at the program level, there's hours of operation that would potentially make a patient wait to get in, and having an alternative or additional non-traditional model to get them in could be helpful. A big elephant in the room, right? What's covered in terms of insurance? Is insurance covered? Is insurance cover a hybrid or the virtual component of hybrid cardiac rehab? Health Alliance Plan does cover it. State of Blue Cross Blue Shield in the state of Michigan does cover it. But a big one has to do with Medicare, right? So in the 2023-2024 118th Congress that wrapped up in December, cardiac rehabilitation at home was part of a telehealth bill. It was introduced in the 118th Congress. It got pulled out when they had this end of December quirks that were going on in Congress at the time in terms of getting things passed, and what was embedded into the telehealth bill got pulled out. I am happy to share that within the past 2 weeks, Representative Joyce from Pennsylvania reintroduced the cardiac rehabilitation patients at home model. Our hope that it will be tagged into the telehealth bill. So it's been reintroduced, but that it gets pushed into the telehealth bill that's going to be looked at in March. So we're back to stay tuned on where things stand with that. So a little bit about hybrid, and here's 6 questions that I want to bounce through. The one is, do patients have the needed equipment at home? 2 is it safe? When patients are exercising at home, because they're not under supervision, do they become less intense in terms of their exercise habits? In terms of outcomes, do they attend regularly compared to brick and mortar? Are the improvements in exercise capacity and quality of life similar? And what's the burden on the staff that's responsible for implementing it? So I want to bounce through these. probably just one or two slides on each of them. So some of this data is going to come out of a randomized trial we wrapped up about a year ago. And we randomized 142 patients, and this was an NIH-funded trial, the hybrid cardiac rehabilitation, and compared those to 140 patients that were randomized to facility-based only. So if I talk about the IA-10 trial, I'm filtering out some of the data or process elements along the way. For the trial, we had a mean age of about 60, a little younger than I liked, 30% women, really pleased with 50% Black race. And just to emphasize that, like many other trials in cardiology, Blacks are underrepresented, and cardiac rehabilitation is no less. So very pleased that we had 50% Black race. I've listed out the qualifying events. We had a really good smattering across the board. 20+% were heart failure, which is important because heart failure is mentioned by any as a safety issue about maybe they shouldn't be in a home-based program, but we included them nonetheless, and we'll show you their data in a second. So in terms of home exercise equipment, we want to keep it simple. You've heard of all kinds of programs that give people Fitbits and blood pressure cuffs and monitoring devices and all kinds of things. We try to keep it really simple at Henry Ford. We want to make sure they have a piece of exercise equipment they can access, whether it's at home or in the community or at work. Hopefully it's got some kind of scale information on it where we can measure either miles per hour or incline or watts, something that we can quantify. And the only thing we gave patients is into the far right corner here is a pulse ox device. These are able to give us heart rates for people that don't have atrial fibrillation or pacemaker or cardiac transplant. We're able to get some heart rate based information from them. If the patients don't have home exercise equipment, then we'll work with them outdoors in better weather, obviously. But in bad weather, I mean, we had one patient who worked with AT&T. He had great Wi-Fi connections in the building. So he just walked the hallways or had a route for in the building, and that worked out just fine. So point is, keep it simple. You don't have to over expense this out. Meet the patients where they live, and usually, most always, we can find some approach to get the patients their exercise equipment and monitoring. In our trial, IA-10, we were able to get 97% of the patients had a smart device, cell phone, or internet access, which, this is the city of Detroit, guys, and it had high penetration for this need. And we were still able to solve the access to exercise equipment in 80% of the patients we touched, which is very, very good. We were pleased with that. Next question is the virtual component of cardiac rehabilitation safe? The first point I want to emphasize is you guys have to believe me when I say we've been telling patients to exercise at home for decades, and now we're asking if it's safe. So we've been telling patients in brick and mortar, on the days you don't come here, please exercise on your own. But that being what it is, the safety issue has come up. In the IA-10 trial, we had 8,000 patient visits. 4,000 of them, more than that, were conducted virtually. We had no patients in the hybrid group that were asked to come in to fill as facility-based extra because we thought there was a clinical concern, so that's a good signal. None of the virtual visits required physician involvement where we had to pull them into the phone call or the connect. There were no mechanical falls in either study group that required medical attention. And there was one non-fatal stroke in a patient in the virtual group that occurred 3 hours after they were done with the session. The patient was actually in Walmart and experienced their non-fatal stroke. And then finally, I bring what I think really is the linchpin of the safety issue to you. This is the HF Action trial that enrolled over 2,000 patients with HFrEF. randomized them to facility-based cardiac rehab that was then followed by home exercise versus usual care. Here we compared hospitalizations between the two groups, which we defined as within 3 hours after exercise, and it was in 2% in one group and 3% in the other group. Mortality in both groups was around less than 1% at 0.4%. So again, really good evidence that patients with stable patients that are well screened can get into cardiac rehabilitation, whether it's remote, at home, et cetera, non-traditional or in facility-based. Another common question is patients that are randomized to home-based or the remote program, do they slack off when they're on their own at home or under supervision at home in terms of exercising less intense? And this was a study that we published about 3 years ago using 2 years ago, using some of the initial IA-10 data. The x-axis is the number of sessions across rehab, up to 36. The y-axis is exercise intensity using heart rate-based math. It's called the heart rate reserve formula as our index of exercise intensity. The blue line is hybrid patients. The red line is facility-based. We want to exercise patients initially around 60% and then progress them up to 70 or 75%. And you see both groups are parallel. Both groups started in the low 60s and got up near 70, a little less than we would like. So that was a teaching point to the staff that you need to progress patients more in both groups. And we did talk to them about that to push them to higher intensity levels, but no difference between the two groups. Another one is, okay, if you put patients at home, do they hopefully do more sessions or at least equivalent number of sessions, or do they slack off and do less of their sessions at home compared to facility-based? And this actually was the primary endpoint for the trial. And you can see here we have total number of sessions on the first row, and then percent of patients completing all 36. There was no difference, and you can see the p-value. There was no difference between facility-based or hybrid. Both completed about 28 or 29 of the 36 that were prescribed. And if you express the percent of completion of all 36, you can see there again was no difference, around 51 to 59%, no statistical difference between the two groups. So one could argue that as a non-traditional alternative way to deliver cardiac rehabilitation, clearly hybrid is not inferior to facility-based in terms of attendance. Well, we also have other outcomes that we look at, and those would be exercise capacity, because we know cardiac rehabilitation is a big driver of improving exercise capacity, and improvements in exercise capacity are linked to decreases in hospitalizations and linked to decreases in mortality, and then also quality of life. That's another secondary outcome. We have 3 measures of exercise capacity. Peak oxygen uptake, which is a quantified way of looking at a person's fitness level, measuring literally exhaled air for the amount of oxygen consumed. Exercise on time on the treadmill, and then the distance walked during a 6-minute walk period of time. I draw your attention to the blue columns. These are the mean changes in peak VO2, exercise time, and meters walked. And you can see comparing the two groups, change in the facility-based group to change in the hybrid group for each of the 3 exercise capacity. And important, we want to improve exercise capacity because it's linked to outcomes. You can see statistically no difference between group. Here I give you the group difference and then the 95% confidence intervals, and in no place do we cross 0. So exercise capacity similarly improved. Health-related quality of life, you can see down here, kind of health status, decreased in both group about 3 to 4 units. This is the Dartmouth. Lower is better in terms of quality of life. And you can see it decreased similarly in both groups. Again, statistically, no difference between the two groups. Okay, a final question that we have is there a big staff burden? And we're always concerned about patient burden, right? When they come to the health system, how many hoops do we have to have patients, leap through to get their clinic appointments done or rehab done? But we also have to be cognizant of staff burden. I mean, we want patient satisfaction, but staff satisfaction as well. So we try to, again, keep it simple. We want to keep it just like these hybrid visits, these virtual visits, just like facility-based cardiac rehab as much as we can. So a patient comes in, quick interview, symptom assessment. Patients, we're doing this virtually now. Patient's location is confirmed on the zero chance so far, but rare chance we would have to send some type of emergency transport systems there. We capture heart rate and body weight. They do 5-minute warm up, and then they have 30 minutes of aerobic where we're periodically documenting from them what equipment they're using, what workload we're doing, what heart rates are at, what their level of perceived exertion is, RPE, rating of perceived exertion. So we're getting feedback from them on how they're tolerating the exercise. And the same conversations that we have with them during facility-based are what we have with them remotely. I mean, it could be the golf game, right? How's your golf game doing? Or it could literally be risk factor management. We'll show videos of the dietary lectures. This is when they get their extra education. We stop the videos right during the sessions, ask some trigger questions to get conversations going, replay the next part of the video, and then ask more questions. Or again, it might just be a group chat. But it does bring in that group camaraderie that you like to have by getting people together because they talk amongst themselves, which is what occurs in a facility-based session. So that's kind of like hybrid cardiac rehabilitation description and outcomes. I want to just kind of go into my home stretch here and talk just a little bit about some other elements that are pertinent to hybrid and non-traditional cardiac rehab. So the first issue is there's no surprise, there's a supply-demand mismatch for cardiac rehabilitation in the US. On the left there on the demand side, you can see if everybody that had a qualifying event, whereas on the left side there, 500 first acute MIs, 300,000 bypasses every year, 200,000 PCIs, and 400,000 heart failure admits or discharges, boy, that would really weigh down heavy on the demand side. Well, the supply side is cardiac rehabilitation. And if the point is, though, is if we revved up all the rehab programs that are brick and mortar in the US now, and even took them up 10%, we would only handle 50% of everything that comes in on the demand side. So we have to have alternate ways to deliver cardiac rehab, or we have to really make an awful lot of new programs, which in these resource environments, not going to happen. So we need new delivery models is what I'm trying to emphasize. So what we want to do then is expand the cardiac rehabilitation paradigm. And you can see on the left here, the current paradigm shows we're getting about nationally about 29% of the patient through brick and mortar, traditional cardiac rehab. We've got a very low percent, probably even thinner than I could show here, of people that are using home-based or non-traditional models, and a lot of patients that aren't being serviced. So what we want to do is grow the facility-based. Yes, 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 we want to grow the facility-based. We want to do that. But to get the 70%, we have to really grow the non-traditional models that are out there to really shrink the number of patients down to 30% that don't get cardiac rehabilitation. So we really have to, expand this model here to close the treatment gap. Okay, last couple slides. So I'm the first to say that as we talk to other hospitals, that might have interest in doing a hybrid model. And when you really get under the covers with them and talk about the granularity, a lot of barriers start to flash. Well, I don't have enough staff, or my staff's not going to adapt to this, or there's really not much expense, but there are there are items that come along that would maybe get in the way of Alpena Hospital. I don't mean to pick on Alpena, but Alpena Hospital saying, we just can't do this based upon staffing or whatever it happens to be. So one model that we would like to test is a hub and spoke model. And that maybe there's 2 or 3 or 4 centers in Michigan that has remote up and running, and incorporating patients from other hospitals would be easy. Instead of having 3 or 4 patients in the group, we'd have 4 or 5 patients in the group. The patients would go back to their local Alpena hospital again, but go back to their local Alpena hospital to do their brick and mortar for their 1, 2, 3, 12 sessions, but they virtually could be connected with Henry Ford or another site that has the capability to go ahead and do the virtual component. So this hub and spoke model is something we've talked about probably for 3 or 4 years. Within the health system, we hope to beta test it with Wyandotte Hospital. It's in the system. We've got the same EMR. We talk the same language. So we may test it with with our colleagues there for 2 or 3 patients. But ultimately, we need to test this on 30 or 40 or 50 patients just to see how it goes. I've got no money for this. It literally is, or maybe there'll be money down the road, but it literally is us just, if the patient gets their facility-based visit with somebody else, then they would charge for that and get reimbursed for that. And if they come to Henry Ford for their virtual sessions, then we'd have to figure out, how we cover those costs. But I throw it out there. If you're interested get a hold of me. I'm not that hard to find. Get a hold of me, and I'd like to talk to you about it. And it doesn't have to be today, but talk to your staff. But if you have a value-based model there, this would fit right in, right? I mean, this would be an ideal way to provide the care. So I just throw that out there for consideration. So what do I want you to take away from today? One is one non-traditional model to deliver cardiac rehabilitation is hybrid CR, but it is just one tool in the toolbox. It's not your only tool. There are others that are out there that may come along, maybe an asynchronous model. We use the synchronous model where the patients are exercising under supervision, but it is just one tool. It's not the only tool. We think it's safe. We believe it's safe. We think the data is there. And the patients exercise at an intensity that's sufficient to induce the training effect that we want. It results in similar attendance and quality of life and exercise capacity improvements that we think are equivalent to facility-based. But having said all this, we really have to blow this up a little bit, and others are getting there. These non-traditional models, if we really want to close the treatment gap that we're witnessing today for getting patients into cardiac rehabilitation, which I should have started, which is a class 1 recommendation, expert panel consensus recommendation for patients with cardiovascular disease. So Emily, I'm going to stop. Maybe you could take me off share, and if there's questions that have come in, I am happy to assist with that.
Let me unmute myself. Thank you so much, Dr. Keteyian. We did have a couple of questions that came up. I'm just gonna take back the slides here. There we go. Just got our question slide up. So looking through the chat, let's see, from Stacy Sparks. Stacy was wondering if you rely upon patients to self-report their heart rate and other sort of data during their exercise sessions, or does the staff have the ability to monitor it using the devices that were provided to the patient, like the oxygen?
Yeah, it's a good question. It's self-report. So literally, if we ask for their heart rate, they'll look at their pulse ox and say what number they have right there. We do also ask for their rating of perceived exertion, which is self-report. We've taught them how to use that tool as another reason check, so to speak, to make sure they're within the training range that we want them. Could somebody be technically seeing one number and telling us another? That would be true. We hope that's not the case. We don't witness that in facility-based, and we have no indication of that so far in virtual. But I guess that could be true.
Thank
But to
you.
keep costs down, we've done with these simple $30 pulse oxes is what we give the patients.
Great. Um, Marie is wondering, have you compared the important social aspects of cardiac rehab in the hybrid program versus facility-based? You mentioned that they talk during the Zoom sessions, but so much more happens in person.
So that exists, right? We know there's a difference. We know that going in, but again, the patients do communicate. There is socialization, and you have to believe me, if you see one of these, it is quite robust sometimes. We've also had some people say, I wish everybody else would stop talking. I just want to exercise and don't want to hear all this noise. So we've seen both extremes along the way, but there can be quite robust discussions or just conversation. And then there's discussion around nutrition. But our hope is what we might be sacrificing a little bit in terms of the camaraderie and socialization of virtual versus in person, we're picking up by we're getting to them where they wanted to be. By that I mean I can't get here because of work, or I can't be here because I'm not comfortable, or I've got dependent care, child duties or adult care duties that I have. That the win is better than maybe the little bit we're losing on socialization.
Great. All right. Dawn, thanked you for the excellent presentation, and noted that at Henry Ford St. John Hospital, they closed their cardiac rehab facility in the spring of 2023. And she's wondering how they can team up with you for referring patients to the hybrid program, and do you have capacity to add them?
So probably yes, and both. So we're happy to help. We're all part of the same family now, so we're happy to help. I can just say, find me, email, call, whatever it is, to work your way to me, and or maybe Emily, you could send my email out afterwards, or put it in the chat or something. And you're welcome to get a hold of me. I will say that if we can connect them into hybrid, we'll do our best to do that. We may start them out brick and mortar for a while just to make sure everybody's comfortable, and then move them on their way. But that's the approach we use, but we're happy to accommodate that.
That sounds great. And yes, Dr. Keteyian will include your email in the follow-up email as a CC, so it'll be easy for folks to get in touch with you.
That's fine.
Right. All right, another question from Stacy. Is there a specific staff to patient ratio that you target during a hybrid cardiac rehab session?
So these are good questions. So brick and mortar has a staff ratio of 1 to 5, 1 to 6. And we want to keep everything the same, right? So technically we try to go no more than 1 to 5, 1 to 6. I can honestly tell you 1 to 4 pretty much stretches the limit. Just because you've got EMR stuff you're doing at the same time, and you're juggling a little bit more buttons and clicks along the way. So 1 to 3, 1 to 4 seems to be the sweet spot that we shoot for. 1 to 1, it kind of is a little bit, like you can only talk about so much so long with one person while you're doing it. So we'd like to have 2, 3, or 4 people in the group just to keep the conversation going. But above 4, our experience is, staff kind of says, they're getting shy now.
Great. Let's see. Oh, yep. So Sarah just asked if you supply patients with equipment they need to monitor themselves. I think this was brought up just before she was able to join us.
Yeah.
Um,
So
so
Sarah, it simply is that we give them a $30 pulse ox that you would use in any place in a clinical setting. And that's the only expense. Most everybody has scales or is able to track their weight. But from the pulse ox, all we're using, fingertip, all we're using is heart rate.
Mhm. If anybody also wants to unmute themselves and ask a question out loud, otherwise I'll keep my eye on the chat.
I have a quick question if you'll let me, Emily.
Of course,
Hi,
Anna.
Dr. Keteyian. Nice to see
Hi,
you again.
Jana. Yeah.
I wonder if you mentioned that both HAP and Blue Cross cover at this point. Is there a difference in the reimbursement that they are providing for for a facility versus remote?
Yeah, so the short answer is I think, no, there is a difference. But billing is such a black box enigma to me.
Yeah.
I just, what I mean? I just can't find my way through that. When I talk to billing people, it's like I'm literally listening to Greek. So, so,
Yeah.
but the bottom line is we check the numbers. Melissa in our office has a good feel for that. In general, yes.
A
The
little bit.
processes for billing it seem to be different between HAP and Blue Cross Blue Shield. I can't figure out why, and the amount seems to be a little bit less. Medicare, I just forget which one because during the public health emergency we were doing Medicare, right?
Yeah.
But I think that was better. It might have been 40, it might have been like 40 or 50 cents on the dollar. So pretty typical of what brick and mortar was as well.
Okay. Thank you.
Thank you, Jana. All right, well, I was just going to pose the question. Dawn reached out and said they were interested in potentially participating in this hybrid approach. Now they're within your family with Henry Ford now. Is there anyone else on the call that would be interested in that hub and spoke model or have tried in the past to integrate kind of an alternative delivery model for cardiac rehab that you could speak to?
I kind of put that out there as a lark. So if
Yeah,
nobody wants to, that's fine. Or if they stew on it for a while and think about it later, that would be fine. But I think it's a testable idea. So that's why we wanted to do it.
definitely. Okay. I had a question for you, Dr. Keteyian. And it was sort of spurred by Don's mention that the St. John location had their cardiac rehab program closed. Given that there is a demand, and you're seeing sort of this need for us to be able to reach those 70% goals for cardiac rehab, what is happening in that we're seeing some cardiac rehab programs close across the state? Is that to do with reimbursement or other factors to your knowledge?
So, so obviously it's resources, right?
Mhm.
And I, my sense is for the couple people I've talked to, and even physician leadership that I've talked to, they've had to make a decision. We've got limited resources, and we've decided to, withdraw monies to pay for staffing over here so that we can pay for staffing over there.
Mm-hmm.
It's been a resource um, utilization issue or money issue, right?
Mm-hmm.
I can tell you that it's done with great disappointment, both on our end and on the people that are making the decisions. And many programs that were up and running before COVID have not come back since COVID. Since COVID, some have actually then further been closed down. We're in that sense, we're going in the wrong direction. And I don't want people to make light of that at all. It concerns me, it concerns many others, but usually the scenario is, we're not making a lot of money on cardiac rehabilitation. I can take that same round number, $100,000 and make $200,000 off of it if I'm doing blah, blah, blah. And that's where we're at.
Okay.
It's unfortunate.
It is unfortunate.
And just to be clear, it's part of the continuum of care. I mean, I'm not pulling this out of my hat. It's well integrated as a class 1 expert panel, recommendation for consensus guidelines. So to go against that grain to me, and without looking at anybody else on the screen, I will just say we've never had that problem within Henry Ford. So I hope as other people come into our family that we can help them get back started or get them online, and because that's the model that we want to advocate within the system.
Great. All right. I'm not seeing any more.
Can I have another one?
Yeah.
This is a little bit off topic, so I hope that's okay. I remember looking back at the graph on different rates of enrollment by service line. Do you have any hypotheses about why it differs so much, between a CABG and a TAVR and I know that the CHF and AMI are lower for different reasons, but even between like a PCI and a CABG, is that at the physician level that they have preferences about that, or what's going on there?
So yes to both. Is partly at the physician level. I can't begin to emphasize, and they do well here at Henry Ford. But physician endorsement, provider endorsement, APP endorsement really does drive it improves participation rates. So yes, it could be at the physician level, because some physicians will have said, I've heard them say, you've had your stent placed, go ahead and do whatever you want. Do I need to get into cardiac rehabilitation? No, just go ahead and exercise on your own. Literally, I'm paraphrasing what I've heard. So on the provider side, yes, that affects it less so today than, let's say, 15 years ago. So it's gotten better, and I'll be the first to applaud that and acknowledge that. But on the patient side, there seems to be a perception of I've had major heart surgery versus I literally just had some plumbing done and I'm on my way in 3 or 4 days. We do combat that a lot. And for patients to understand, we try to meet with patients before they go home, don't always get there, right? Before they're discharged, and tell them it's, what got you here was a whole host of factors, wasn't just exercise. And that's what we want to work on in cardiac rehabilitation. Sometimes that resonates, and sometimes it does not. But the perception of the illness is of a greater magnitude, so to speak, with, having their chest opened up versus, going in through a, vascular access.
Yeah, that makes sense.
Had one more
And when
question.
sorry.
Sorry, Jana, go ahead. Do you had a
Sorry. When you're sort of identifying patients for hybrid, are they sort of self-selecting into that, or is that something that when you first start talking about enrolling, even before they're discharged, are they told that this option is there?
So we're getting better.
When are they first exposed to it?
We're getting better at that, Jana. That we would like it to be when they're first exposed. So as we're talking about cardiac rehabilitation, we'd like the phraseology to be, we can do you in a model where you do much of it at home. You can come here for all your visits, blah, 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 blah. So we'd like it to be at that level. But I will tell you, in reality, with the staff, it's also, well, I can't come because of XYZ, and then it's introduced. So we'd like the former to occur, but the latter still happens, and we're working on that.
Okay, thank you.
All right, kind of coming off of that, we did have one other question come in through the chat. Marie is wondering if you see differences between female male participation between brick and mortar or hybrid. I know you had given us some demographics of the participants of your trial, and that was off the top of my head, I'm remembering, I think it was a pretty even split. But I'm wondering if there's anything else to that idea that you'd like to add, male-female participation.
So we had about 30% women in the trial. So we thought we had a decent sampling. It wasn't 50%, but a decent sampling. And one of the problems with us running I attend when we did is that we got caught up in COVID.
Mm.
And that is everything in life confounded everything, even the trial, right? Conduct. So we literally had patients saying, please, can I come in for my facility visits most all the time if you're going to let me have them, because I got to be around other people. I just don't like being home the whole time. So take that as, a grain of salt that's out there, right? But having said that, the literature will show that women are more reluctant to exercise in front of others than men, especially in older women. We didn't necessarily see that as we hear comments from that in the trial, but I'm just giving you what the literature will support, and that's Teresa Becky's work in Florida has observed that. But so we didn't really observe any specific demographics that said, or scenarios that said, I really need to come in. Having said that, there were 2 patients in the hybrid group that said, I know I've been assigned to the at-home group, but I don't feel safe being at home. Can I come in for my visits in brick and mortar? And obviously we said yes. So that's the only signal, and it was on 2 patients that just didn't feel comfortable being on their own at home.
All right. So I'm going to progress us through just a couple of closing slides. If any other questions do come through, I will send those your way, Dr. Keteyian.
I'm going to step off. Thank
Okay,
you very
sounds
much.
great. Thank you so much.
Yeah, bye now.
All right. So just a reminder that we've got some upcoming work groups. One additional February work group this month will be our Health in Action on February 27th. This is going to be hosted by MVC, our project manager, Jana, who spoke up quite a bit today. She will be briefly covering patient journey mapping, and then we'll also host sort of a workshop portion of that work group. And then Tuesday, March 11th, we will host our next Rural Health Work Group. That's going to be co-hosted by the Michigan Center for Rural Health and the National Kidney Foundation. Also happens to be during National Kidney Health Month, I believe. If you missed our last couple of work groups, you can read the highlights in last month's work group summary blog that's available on our website. And then be sure to look out for a summary of February's work groups, including today's work group that will come out at the beginning of next month. All right. And then last but not least, just a couple of additional items. Our P4P final scorecards will be coming out imminently, hopefully in the next day or two. And then we have our spring collaborative wide meeting on May 9th. That is going to be hosted at the H Hotel in Midland, Michigan, and we would love to see you there. We are having a call for presenters for upcoming MVC events, including our work groups, the Spring Collaborative Wide Meeting, and more. So if you are interested in preparing a presentation or have a topic that you think might lend itself to a presentation with MVC, we'd love to hear from you. And that presentation proposal form will be linked in the slides that I will send out following the work group. We can pop the link for the survey in the chat, Rachel, if you haven't yet. I can do it.
Sorry, it wasn't loading for me.
It's okay, I got it. All right, so that link is available in the chat. It will also be in the follow-up email. If you have any questions or concerns, feel free to hang on. I'll hang out here for the next couple of minutes. Otherwise, thank you for coming.